Good afternoon, ladies and gentlemen. If we may have your attention, welcome to the pediatric session. As our final speaker, it's my pleasure to introduce Professor Robert Harmon-Giles, who's well known to most of you in the audience. Professor Harmon-Giles is the head of the Department of Nuclear Medicine at the Children's Hospital in Westmead, and his talk is entitled PET-CT in the Evaluation of Uncommon and Rare Malignancies. Thank you.
Thank you, Eva. The aim of my talk really is we've just heard two excellent discussions on the common tumours, basically lymphoma and sarcoma, in the paediatric population. And what I wanted to do was just to show you that you can extend your mind a little bit when you're actually asked about by your oncologist about these rarer and more uncommon tumours. At our institution, the first time we got this PET-CT in the conjoint facility with the adult hospital was 2006, and we've done over 6,000 PET studies. And if we just look at the pie graph here on the right-hand side, if we look at our numbers here, lymphoma are basically 40% of the studies. Sarcoma is about 30% if you combine bone and soft tissue. And then we have about a third of the patients who are groups of other paediatric cancers, of which there's often not a lot of data about the benefit of the PET imaging with that. And that's what I'm going to talk about in the next 20 minutes. So if we look, I've got other common. So what I mean by that is that there are some common tumours, for example, neuroblastoma, where PET is used, but it's not routinely used from the point of view of the patient management. And similarly, for example, with Wilms tumour. I apologise about my voice, I've got a bit of a cold. So we're going to just go through some of these cases just to give you the idea that yes, you can do PET imaging if you have a malignant tumour. And quite often the pathology people have some difficulties in the undifferentiated, for example, small cell cancers. So the concept of FDG basically is the FDG uptake is increased due to upregulation of the transporters. And so we see it as an increased metabolism of aggressive malignant cells. At our institution, we basically commonly use glucose, or pretty well for 80% or so more. We have access to FET and also the gallium somatostatin agent, particularly gallium-68 dotatate. So if we just look at some of these now, the two common ones that I want to discuss was, the first one is neuroblastoma, and really just the theranostic approach of MIBG in the paediatric neuroblastoma group. The I123 MIBG is basically the recommended agent for diagnostic imaging in neuroblastoma, and basically also if they have positive MIBG uptake, then they may be able to have MIBG therapy. More recently, we've been looking at somatostatin receptors in the paediatric neuroblastoma, and in some cases FDG, but again, that's not routinely used. Again, the theranostic approach is that if you have positive somatostatin receptors, 89% of the population, we can treat them with lutate, or hopefully coming up soon, copper-67 sartate. So here's an example. This is an 18-month-old child with neuroblastoma, but when he came in, the tumour looked like it was actually rising from the liver. So as we do our PET scans on one day a week, on Thursdays, this patient came in on the Wednesday, we flicked him onto the list because we thought it was more likely to be a malignant liver tumour. So we can see here this MIP at the staging. So he's got obviously a big tumour in this right-hand side of the abdomen extending across the midline, and a lot of metastatic disease in nodes and the skeleton. But we can use FDG similar to MIBG, but looking at response, which we can see here in the first, after several cycles of chemotherapy, and then here towards the end or at the end of his treatment, but there is still positive disease. There's a very good paper, probably the main paper, by Barry Shulkin and the Cincinnati group in comparing I123 MIBG and FDG PET in neuroblastoma. I think the two main points from this publication is that if there's no or poor uptake of MIBG in the patient, which is about between 5 and 10% overall, then obviously the PET FDG is very useful. I think the number four is the amazing thing really from the point of view of this, is that the MIBG was overall superior in delineating stage 4 disease, which is the majority of the population, particularly in the bone and bone marrow, because of the issues we have with bone marrow in FDG uptake after having chemotherapy. More recently, there have been 2 papers in 2016 and 2011, the first one from University College London, about somatostatin's imaging and therapy in neuroblastoma. So here's an example. This is a 9-year-old girl. She was stage 4 disease, refractory to chemotherapy. She'd had a surgical resection, and she was progressing after all the various programs. So on the left-hand side here, we have the I123 MIBG, and we can see that there's metastatic disease extending around through some of the vertebral bodies, etc. But when you compare it to the dotatate study, we can see that the images, the foci are much, much clearer. And certainly you're seeing a lot more disease. For example, if we look at this right proximal femur and then look at the somatostatin imaging, you can see how more extensive it is. So certainly, and in the group from Melbourne at the Peter Mac, they found that there was at least, I think, 30% that had more lesions detected on the somatostatin, the dotatate study, than the MIBG. So that moves us on to the theranostic approach with the somatostatin receptor, and this is just an example. This 6-year-old male who had progressive stage 4 disease, as you can see here, and this imaging was done to see whether he did have somatostatin receptors. His problem was the massive uptake of abnormal tissue in the skull, and he was getting quite severe pain. He was breaking through all his therapies from the point of view of control of pain. And so they thought, well, maybe we could look at using lutate in this boy, which we did, and he got 5 gigs of lutate, and he had very good uptake into these massive tumours in the skull, but also obviously the lung disease in the skeleton. And he actually, over an 8-week period, did have a significant palliative effect. He continued to progress, and he died at about sort of 10 weeks after the imaging, but the carers felt that there was a significant palliative effect. Wilms tumour, excuse me for a moment. PET is not a routine in Wilms tumour, and we occasionally are asked to do a PET in these patients, particularly if they're large, extensive tumours. Stage 4 basically with metastatic disease, and this is an example, a 20-month-old female who presented with a large abdominal mass, which we can see here on the PET imaging, with obviously abdominal nodes involved. And the question here was really more, how are we going to assess the response to the treatment? And they felt that it would be better if we could look at this metabolically. So on the left here, this is the diagnostic imaging with very marked uptake that we were seeing just on that slide before. After chemotherapy, basically, there's been a really good response. The metastatic disease in the liver, for example, is now hypometabolic, and so it was obviously a very good response to the chemotherapy. And the patient went to surgery, had the primary tumour removed and the hepatic metastases, and there was no viable tissue found. The patient went on to have further radiotherapy. Again, a very good paper by Barry and the Cincinnati group, and also British Columbia, looked at FDG in Wilms tumour, and the final comment really with regards to the metastatic disease and the application in this tumour was it was better in defining extent of disease and also in response assessment. So certainly we don't do it routinely, but in a small number of patients we would be asked to do FDG PET. Primary liver malignancy, again a fairly rare tumour, and the main ones we see here are hepatoblastoma, or in a smaller population, the hepatocellular carcinoma. The overall sensitivity of PET in adult HCC is very variable, between 50 and 65%. However, in the paediatric population, we have found that the greater majority of these are positive on PET. Where we utilise this, again, is quite restricted in a way. And in this top case here, this is a 4-year-old girl who had hepatoblastoma, which is involving the left lobe of the liver. And the surgeons were just concerned about where their surgical margin was going to be. So they were wondering whether the FDG PET would help define that surgical margin, which we got, when we look at the PET image here, we can see quite clearly the area where they felt that this was the sort of main sort of resection margin, and they felt that the PET was actually very useful in this particular patient. Probably the commonest indication in this group of patients is after they've had surgery, if they have increasing levels of alpha-fetoprotein. And so in this particular case, you can see this is a different patient. This is a 9-year-old male with hepatocellular carcinoma, had his left lobe of the liver removed, but then had a high rising alpha-fetoprotein. The CT was equivocal from the point of view of determining where the area of recurrence or of disease was, but the PET quite clearly showed uptake in that area in the margin of the resection margin there. We also found in a small group of patients that we analysed that if the alpha-fetoprotein was less than 1,000, then the recurrence that they found was usually less than 10 millimetres in diameter. And that meant that the actual conventional imaging, for example CT and MR, could often have difficulty seeing that. Okay, germ cell tumours, again a rare tumour, but 1 to 3% of childhood tumours. 20% of these are malignant. There is some pathological differences between the young children and adolescents. And again, it's usually alpha-fetoprotein that they're following clinically, and that we're actually asked to do a scan just to determine where that's coming from. So here's an example, 11-year-old male. He had this patient when he was 3 days old, had a mass, a sacrococcygeal teratoma, which was removed surgically. And then again, with a high alpha-fetoprotein in follow-up, 23,000, he was sent in to be assessed. So basically a mass was found within the pelvis, and as you can see here on the PET imaging, if we just look at the bottom row, there's sort of increased uptake in that area. It's not greatly high, but it's around about 3, but there was no evidence of any metastatic disease, and this also turned out at surgery to be a malignant yolk sac tumour. Basically, we're also asked to do in PET scans in patients with germ cell tumours if there's a mass. So this particular patient had his right testis removed for a mixed non-seminomatous malignant germ cell tumour, and in follow-up he was having a PET scan, and he had this increased mass sitting in the paravertebral region, which is sort of lymph nodes, and with increased metabolic uptake. After chemotherapy, basically this became hypometabolic, so the response was very good. Patient had surgery when this was removed, and there were still some pathological germ cells there, but they are now mature germ cells. Now, just discussed the sarcoma group, but there's also a group of these sarcomas which are quite rare and often difficult to sort of characterise. And the soft tissue tumours with non-rhabdomyosarcoma comprise about 4 to 5% of childhood tumours, of the sarcoma group, of childhood tumours. And the ones I wanted to just talk about now, which I'll just show a case, synovial sarcoma, which are very rare, and one which is more common, the malignant peripheral nerve sheath tumour. So this was a 13-year-old male who presented, originally had a history of Wilms tumour. He had chemotherapy, surgery, and then radiotherapy, and he represented with an abdominal pelvic mass, which you can see here on the CT, with a large area of what is obviously central necrosis of the tumour. And when we look at the PET CT, again, we got quite high uptake, SUV max of 8, showing this sort of malignant tissue. Again, there was no evidence of metastatic disease, and this patient had this resected surgically, and this was a synovial sarcoma. Now, a group that we've been interested in recent years is the Langerhan cell histiocytosis group, and we appear to be doing more. There are more requests for doing PET scans in these patients with the more aggressive forms of LCH. Basically, there's a wide range of clinical presentations of LCH. If it's single organ, where it's skin or bone, or multifocal, liver, lung, bone marrow, and CNS. And the course of the disease depends on that degree of aggressiveness. And in some of these patients with LCH, they may spontaneously regress, but there are those who also may continue and have rapid progression to death. So this is an example of a 2-year-old male who presented with a limp. And as we can see on this CT, there's a lytic lesion in that right iliac bone, and the MR shows quite a large soft tissue mass in that area. And we thought at this particular time, even though the patient is quite young for Ewing's, that this is most likely a Ewing sarcoma. He had a PET scan. There's quite high uptake of 7.3 in that tumour in the iliac bone, but he also had metastatic disease in the right ribs and up here in his left temporal bone in the mastoid region. Biopsy was a Langerhan cell histiocytosis. We used PET then to look at response. So he had chemotherapy for 3 months and he showed a very good response to the chemotherapy. Probably the major paper with regards to LCH is this one here by Phillips et al. From Baylor College of Medicine and Texas Children's Hospital. And they looked at 102 PET scans. And essentially what they found in their final comment was PET detects LCH activity and early response in therapy with greater accuracy than other imaging in bone and soft tissues. So the concept of using PET routinely in these other unusual tumours is very much a positive way of looking at it. We also reviewed our LCH in recent years, and again, I won't go through the numbers here, but again, the same support for the previous paper. We found that FDG is highly sensitive for staging and follow-up in LCH with a very low false positive rate of 2%. Now moving on to malignant peripheral nerve sheath tumours, and these are a tumour that doesn't have to be associated with NF1, but quite commonly is. So this is a girl who presented, a 10-year-old girl with actually presented with pain in the back. A CT localised this lesion, which we can see here in her back, and it was localised. There was no evidence of metastatic disease, and this at surgery was a malignant peripheral nerve sheath tumour. So we co-registered, this is this initial diagnostic scan. You can see the extent of the mass extending into the spinal cord and also involving the vertebral body, all very hot on FDG. So this patient underwent chemotherapy, had surgical resection, and as we can see here, there's a lot of orthopaedic device of screws within the spine, which are going to cause some problems from the point of view of imaging. When we look at this image on MR, we can see there's a lot of artefact from the actual pins in the spine, but on this view here, again on the MR, it's much better defined, where there is an abnormality sitting here in the vertebral body extending into the pedicle, and on PET it shows that this was a positive with increased uptake consistent with recurrence or residual disease in that area. So she actually underwent further chemotherapy and surgery, and she's still going along quite well. So the malignant peripheral nerve sheath tumours in NF1, the risk is between 8 and 13%. So there's it's very important that we follow these patients to make sure that they're not getting this malignant tumour, because they're very aggressive, they metastasise in a high percentage of patients, and it's a poor prognosis. So essentially MR is used in these patients to assess what is happening with the neurofibromas, and essentially we don't do routine PET scans in these patients, but if they have increasing mass or pain increasing mass on the MR, then we're asked to do a PET scan and look at whether there's what the disease is doing there. So there's been quite a few publications with regards to PET and malignant transformation in NF1. We use the total body study and then do delayed imaging at 4 hours if there's increased uptake within various neurofibromas in the patient. So this is an example. This child, 8-year-old female, she had multiple plexiform neuromas, and there was this one sitting up here, up in the upper thorax in the paravertebral region, which we can see here has increased FDG uptake. The SUV was 4.6. She was getting quite a lot of pain, and she also had this focal hotspot here in the right lower leg with an SUV of 2.4. So this paravertebral one in the thorax was a malignant peripheral nerve sheath tumour. This other one down here in the leg was a benign plexiform neuroma. Now this girl unfortunately represented to us, she'd obviously been followed in the NF1 clinic, but she started getting this increasing pain in her left thorax, which we can see here on the MR we have a lesion, and on the FDG uptake there's increased uptake in this region. It was 6.2 on the initial imaging, and after delayed imaging this increased to 6.8, and this was a malignant peripheral nerve sheath tumour. And unfortunately she progressed quite rapidly and had died within about 4 months after this diagnosis. Now we utilised, from the point of view of when do you biopsy these tumours, a grading of over 4. And similarly, the group from Boston published this paper in 2012 and basically showed that the plexiform neuromas are essentially less than 4. There's a slight overlap in the atypical plexiform neuromas, so these will be false positives if we take them out surgically, but that's what would happen. And the uptake is usually greater than 4 if there's malignant transformation. Now, carcinoma, again, this is a tumour that's pretty rare in the paediatric population. It's usually young adolescents if we see them, and the nasopharyngeal carcinoma is the commonest in that particular group. However, the management is the same as the adults, and essentially we do PET, do response assessment, and then follow up depending upon what the way the patient is progressing. Now, just to finish, I wanted to talk about neuroendocrine tumours. Neuroblastoma is a neuroendocrine tumour, but obviously there are the other forms of neuroendocrine tumours that are common in the adult population, but rare in the paediatric population. So this young girl presented at the age of 9, and she presented with hypertension, headaches, abdominal pain. She had elevated catecholamines, and on CT she had a mass in the right para-aortic region, which we can see here. This was positive on I123 MIBG, but there was no metastatic disease. It was surgically removed. It was a paraganglioma, and she was also positive for the SDHB2 gene, which gives us a very high positivity from the point of view of the general population that they would have a pheochromocytoma or paraganglioma. So she represented to us when she was 13 in 2011, again increasing headaches, and the mass at this time was found in the right paravertebral region, which we can see here on the MR imaging. So she had a somatostatin, a gallium-68 dotatate, and we can see that that primary lesion here was hot on dotatate. But we also saw that she actually had this hot lesion sitting up here in her left 6th rib. So she actually had that tumour removed from near the kidney, and also they thought they took out the 6th rib, but with pathology there was no tumour there. So she was initially followed and then came back to us 6 or 8 months later for a further dotatate study. And as we can see, there's still a lesion in the 6th rib, right pedicle, L1 vertebral body, and the left iliac bone sitting over here. So she had now had metastatic disease. So she was referred for peptide receptor radionuclide therapy at one of the 2 institutions in Sydney that at that time were undertaking this therapy at St George Hospital. She had moderate uptake, and she then was followed basically by having sunitinib as the treatment. So we did, over the next 3 to 4 years, 3 further dotatate studies. These lesions were still positive, but staying very stable, and she's recently transferred to an adult hospital for further follow-up. So the main aim for my talk today really was that if there are tumours that don't fit into the normal classification of the lymphomas and sarcomas, they're going to be positive on FDG PET at least, and should be looked at as part of their routine treatment. Thank you very much.